made that story up. Pete, that was a great talk. You've heightened my anxiety about all these 23-year-olds we see with chest pain. I don't know if I'm going to sleep after my Monday evening shift. So, James, thank you for asking me to talk about ultrasound today. As any of you who've worked with me know, I'll take any opportunity to talk about ultrasound. I think ultrasound does provide some of the answers. We work in a field where there's a lot of dark art. It's difficult to navigate these tricky patients we see every day. And I do feel that having some basic ultrasound skills can really heighten your clinical abilities. Today, I don't want to talk to you about how to do ultrasound. I've got 20 minutes, there's 150 of you, it's the wrong forum. What I want to do today is to plant a seed. I want to show you how having these basic ultrasound skills can help you take care of those sick patients wherever you might encounter them. Whether that's on the ward, whether that's in ED, or whether that's as part of some medical sojourn in some far-flung part of the world. And to frame this discussion, I want to tell you a story. Now, you can think of yourselves as my psychiatrist. I'm lying myself down on your couch and I'm going to debrief with you. Because this is a story, this is a case that has stuck with me from the day that it happened. I could describe everything about this case to you as if it happened yesterday. And you might be a bit underwhelmed by it, but I think all of you see these cases at some point during your medical training, whether that be in medical school or afterwards, which push you in a certain direction. And this was it for me. So I was an RMO1. I'd been seconded from my big hospital out to a small peripheral ED, and it was a Saturday. It was about midday. We were having a very busy day. We were having the kind of day that even a big hospital was struggling to deal with, and we weren't set up for that. I had 2 other senior doctors working with me, a registrar and a consultant, and they're in the resuscitation bay dealing with disasters of their own. I got beckoned over to the resuscitation bay in the 3rd one to see some concerned-looking ambulance officers and some even more concerned-looking resus staff. They were wheeling in who looked to be an elderly lady, and they were unpacking her. They said, "James, you need to sort this out." And this was the case. She was 76, and the story from the nursing home staff was that she'd been unwell for the last 2 or 3 days. They said that she'd been having increased work of breathing, that she seemed more short of breath, and she was certainly more drowsy. These nursing homes, they have very difficult staffing levels. That's all the information they could give. Not sure about whether she's been taking her medications, whether she's been having vomiting, diarrhea, whether they're fevers, don't know any of those questions. Socially, she's really only in this low-level care nursing home due to mobility issues. Her arthritis has been getting the better of her, but otherwise her quality of life is excellent. She's sharp, she does crosswords every day, she's very much a personality within there. Her next of kin is her niece, but she's currently uncontractable. Her medical background reads as you would expect it to read. She's got ischemic heart disease is the first thing that lists on this hand of a summary from the nursing home. It doesn't say what that means. Has she had stents? Has she not? Has she actually had an MI? What's her LV ejection fraction like? No idea. She's also got COPD. Again, no idea. Was she a smoker? Don't know. Hypertension, hypercholesterolemia, and every other comorbidity that would make it really difficult to tell what's actually going on. By this time, the patient was on the bed and hooked up to the monitoring, and this is what I was... Sorry, and before I tell you that, so this was her medication list. So I had the comorbidities, and then I had another wad of paper, which I thought might be maybe diaries, but felt like I was unraveling the Dead Sea Scrolls. And as I went through this endless list, I noted a few things in it. So firstly, what stood out to me is that she was on furosemide and bisoprolol. Okay, she's probably got a CCF. She's on Spiriva and Ventolin. Okay, she's definitely got COPD and it probably affects her day to day. Okay, well, as I said, she's on the monitor, and these are the odds that I'm faced with. She's tachycardic, profoundly hypotensive, she's tachypneic, her SATs are currently unrecordable and have been with the ambulance as well, and she's cold. Going through my systematic exam, I have a feel of her hands. She's cold and she's shut down. I move up to her neck. I hope that I can see some sort of JVP I can comment on. I can see nothing. She's got a big neck. There's lots of movement. I don't know what's actually a venous pulsation, what's her artery. Looking at her mouth, I don't know, somewhere between wet and dry. Listen to her heart and there's no murmur, and in her legs she's peripherally edematous on both sides. From a respiratory point of view, she's working pretty hard to breathe. She's using her respiratory muscles. And there's definitely a lot of wheeze. There's a few crackles in the bases, and I try my best to roll her around, but there's not a lot of movement. She just seems very wheezy. I push quite hard in all 4 quadrants and nothing in her belly. And neurologically, she's obviously drowsy. She occasionally opens her eyes to voice, but mostly she just only responds to pain. Pupils are equal. She's moving both arms. She's localizing with both sides, but she's certainly on her way to becoming rotunded. We get some bloods. Well, when I say we get some bloods, what I actually got was a blue cannula sat somewhere between her pinky finger and her knuckle. And I got 1 ml of blood off that, and that went off for a blood gas. I got an ECG and it showed a sinus tachycardia at 120. There was none of the dramatic changes that Pete talked about. And this was the chest x-ray. So I thought to myself, I actually have no idea what is wrong with this lady. She's profoundly unwell, I can tell you that, but my niece could probably have told me that. I try to keep calm, I walk next door, I go in to see the ED consultant and registrar. Again, they can't come to help me. So the nursing staff by this stage are getting a bit anxious. This patient's blood pressure is cycling and it continues to say 72, 74, 76, 72. And they hand me a medication chart. And as my sweaty hand with my trembling pen comes down towards it, I think, okay, well, what am I going to chart? And you guys think about yourselves in my situation. Am I going to chart furosemide or normal saline? I don't know. Am I going to give a Ventolin and Atrovent? Maybe some steroids, maybe some antibiotics? Maybe I should just chart all of it and just hope that something works. So this is where I get to really debrief with you. I guess I want to describe what I did quite embarrassingly, but hopefully you can learn from my mistakes. And to do this, rather than just tell you about how I bumbled through it, I'm actually going to do it in graphical format. So let's start off. So let's on the left-hand side, y-axis, we're going to start with systolic blood pressure between 80 and 100. And we're going to say SATs are somewhere between 100 and very low. And let's call this zone below the 80 systolic mark, let's call that the kill zone, where the longer I keep my patient there, the more organ damage they're getting, the less likely this lady's going to walk out of hospital and have a reasonable quality of life. And we're going to break this down into 30-minute increments. All right, so she enters, she's got a blood pressure in the 70s. I've finished my clinical examination and I'm not quite sure what's going on with her. In terms of the things that are running through my head, she's got known ischemic heart disease, she's got peripheral edema, she's wheezy. Maybe she's got an exacerbation of CCF that I can't really see on the x-ray. Maybe I need to give her some GTN and some Lasix, but her blood pressure's low, okay. Or maybe she's got wheeze because she's got an exacerbation of her COPD and she's got cold sepsis. Old people get that. Maybe she needs some steroids, some bronchodilators, some antibiotics and some fluids. Okay, but maybe those fluids are going to cause her to go into pulmonary edema. She's old, she has mobility issues, she's got swollen legs. Maybe this is DVT turned into massive PE. And maybe that she doesn't need any of these things. Maybe she needs to be thrombolyzed. Heparin. Okay, so these are the things that are running through my head. But, you know, realistically, what do all of us... Okay, well, let's not try and generalise it to you. You guys are probably much clinically better than I was. So let's just say that my decision at this stage, with SATs being unrecordable, was to give a 250ml fluid bolus. And during this time, I'm trying to put in another cannula, I fail. I try and get an arterial blood gas to see what her oxygen saturations are like, I fail. I try and call the niece, that also fails. So by this time we're at the half-hour mark. We had a slight increase in the blood pressure, so I'll give another 250ml while I continue on my path. But unfortunately, the same thing happens. So the blood pressure falls back down now. I'm at where I was to start with, and we're 60 minutes in. We're well within the kill zone here. Okay, well, I haven't done a lot of ICU, in fact any ICU, but I've seen people use metaraminol. It seems to fix numbers and makes people look and feel better. Okay, so let's try that. So I tried that. So I'll give this 0.5 milligrams of aramine. And up, so there's a blood pressure, another 0.5, another 0.5, and I'm feeling like a star at this stage. So we're out of the kill zone, blood pressure's into the 90s, things are looking good. But then I hear this beeping. The SATs are now 84, and the alarm, and everyone is looking at me. I listen to her lungs, her wheeze continues, and I listen to her bases, and the creps are still there. I think that 500 mils of fluid I gave her, they sent her into pulmonary edema. The stats were probably fine before, now they're not. So I panic, and what do? Try to frusemide. Now we're back into the kill zone. So her blood pressure is now 72. By this stage, the ED reg and consultant have mobilised from next door, and the ICU reg, who I'd been repeatedly pleading with to come and help me, had arrived. And there we are. Now, if you're trying to squint your eyes and see what that picture shows, this is what it shows. This was the ICU reg's reaction when she came up to come and help me. She looked at the patient, she looked at the medication chart, she looked at the obs chart of what had happened in the last hour and a half, and she just gave me that horrible thing that my parents gave me when I was younger. I'm not even angry, I'm just disappointed. So I got to the end of that case, she gets whisked off to ICU, they fix her, she goes home, she's fine. So in that sense, I guess it's somewhat underwhelming. But for me, it really affected me, and I thought, there's got to be a better way to do this. There's got to be some way that I can figure out how to deal with these sick patients who it's not clear what the diagnosis is. So my next term was in ICU. So I trotted myself off down there and I thought, okay, well, this is where they keep all the sickest patients in the hospital. Maybe I'll get some tips there. I'll try and absorb everything I can learn from there. So I saw a lot of styles. The first thing was that there seemed to be this subset of doctors who can lie their hands on a patient's hand and somehow know that they need a heparin infusion, somehow know that they need cefepime. Okay, well, I'm not that guy. So then the other style was that they seemed to get hooked up to this chaos of wires that would spiral out of them and spit out these indecipherable numbers that somehow meant that they need either fluids, Lasix or pressors. Sometimes you need all three of them at once. And that also seemed equally confusing to me. By this stage, I was kind of getting a hint that maybe I'd like to do ED. And looking back at these two styles, one, I knew that I wasn't that guy who could just lay their hands on them and know what's going on. Maybe with a lot of training and time, maybe you can head in that direction, but I'm certainly a long way off that yet. And in terms of the lines, same thing. I mean, how long does it take me to put in a line? Realistically, it takes me a long time. I can't have patients with blood pressures of 70s while I faff around putting those in. So when I discovered ultrasound, which is just through some basic teaching sessions, it just felt like this might be the answer for me. I can peer into someone's body and really have an idea of what's going on to complement my physical examination. So I trotted myself off, I did some online training, I did some courses, I even was lucky enough to do an ultrasound skills term for a little while, and I came back to PA as a junior registrar, and my thank you for that was, of course, that my first shift back in RPA, having not been there for about 18 months, was a night shift. So I'm an ED reg, and my first ever registrar shift in a big hospital was a night shift. And lo and behold, who arrives but that same patient? Now, when I say it's that same patient, it wasn't really that same patient, but it was pretty much the same patient. It was an elderly person who was hypotensive, short of breath, who had a chest x-ray which meant nothing to me, who I finished my physical exam with, and I said, I actually have no idea what to do. But now I had this new skill. So I pushed my little friend over there, my little ultrasound machine, and I started off at the lungs. So whenever I walk into the room of one of these sick patients, I'm always thinking about a few things. I firstly always think about, I'm going to have a look at the pump, the heart, at the lungs, and have a look at the pipes that feed that heart, the IVC. So as I said, I started at the lungs, because my first question is, well, is this patient in pulmonary edema? And this is what I find. Some of you will look at this and know exactly what this means. But just so we're all on the same page, what I'm looking at is this patient sitting up in bed, they're short of breath, they're on an oxygen mask, and I put this probe right at the top of their chest in the front of them. So this bright white line here, is actually their pleural line. And you can't see anything behind that, this is all just artifact. This is because you can't see through air on ultrasound. And these bright white torches, which are moving down from that line and moving as the patient breathes, they're called B lines. Now you guys might have heard of B lines before, maybe not in this context. You guys remember when you did chest x-rays and you do see patients with pulmonary edema? As part of those features, they get those little white lines at the edge of their lung that are supposed to be interstitial fluid building up. They're B lines. Well, the B lines you see on ultrasound are exactly the same thing. That is fluid filling up the pockets of interstitium between the alveoli. And so when you stick an ultrasound probe on, you can see those bright white torches. I know immediately that this patient's wheeze isn't COPD, it's edema. I've checked both sides, it's everywhere. Could be other things, but common things occur in common. I move from there down to the pump, the probe on the front of her chest, and this is what I see. So just to be clear again, this is the left ventricle here, this is the mitral valve flowing into it, and the aortic valve coming out. Again, left ventricle here. What do you see about this left ventricle? It's rubbish, isn't it? So her left ventricle is barely moving. It's thin, it's swollen. This is a heart that is screaming to have some help, maybe some drugs, some pressors, and maybe get some fluid taken off it. The last thing she needs from me is a fluid bolus right now. So now I move down to the pipes. Now, when I look at the IVC, I'm trying to class these things into the extremes. Because we know that these things in isolation aren't very helpful. You try and use them as a combination. So are they at one end of the extreme, meaning, let's say the first end is fluid overloaded. Is their IVC very swollen? Because the heart is not dealing with the pressure being fed into it. And as they breathe in and out, and the IVC is exposed to that negative pressure of your breath in, does it not move at all? So those patients, they need some fluid taken off them. They need some Lasix, some GTN. Are they at the other end of the extreme? Do they have an IVC which is flat, and every time they breathe in, it collapses shut? Those patients need some more filling. So this IVC is swollen, it's not moving as this patient breathes. Again, this patient is overloaded. They definitely don't need my fluid. So now, instead of being trembly and sweaty when I give them this medication chart, I kind of know what to do. I know furosemide will probably cause her to get more hypotensive, and if it does anything, it will just make her worse. Normal saline, definitely she doesn't need. Prednisone and Aspirin probably won't hurt her, but will do nothing to make her better. So I get rid of all of that. And now I can call the ICU and say, look, I've got a patient who's in CCF, who's in cardiogenic shock, who needs some very high level care, and I can do that early, not 2.5 hours down the line, within the first 20 minutes of her being there. Let's take another quick example. So imagine that you're covering the orthopedic ward and you get called to a SIRS. There's a 64-year-old male who's day 3 post right total knee and he's having a SIRS for his blood pressure. You go up there and there's a nursing staff and the patient's awake and talking to you, and both of them tell you that he's been sick since yesterday. His main symptoms were that he was feeling really nauseous yesterday, couldn't eat pretty much at all, and he's been coughing. Pretty much ever since the operation he's been coughing, but it definitely got worse yesterday. Today he's been feeling increasingly short of breath and he's got some chest pain as well. His background is he's got ischemic heart disease. He had some stents a couple of years ago and he's been told his heart isn't as good as it used to be, but that was all elsewhere. It didn't happen at PA where you're seeing him. Hypertension, hyperglycemia, and he's on all the usual medications that you would expect. So again, you examine him. He looks unwell, he looks sweaty, he's tachycardic, hypotensive, he's hypoxic, and he's got a respiratory rate of 26. He's got a low-grade fever. To examine him, again, you feel his pulse, you feel his hands. He feels kind of warm-ish, I don't know. He's got a rapid pulse. His JVP is somewhere in the middle of his neck, you're not quite sure. His mucous membranes don't seem obviously dry, and he's got no obvious murmur. He's got peripheral edema, but particularly on the knee that he had the surgery on, that's very swollen. Don't know whether that's normal or not. I don't know, he's had a total knee replacement. It seems like he should get swelling. You listen to his chest, again, he's got a few scattered wheeze, and when you ask him about it, yeah, I do get wheezy from time to time. He used to be a smoker. And he's got a few creps in his bases. Again, his belly's benign, but this guy, unlike the last patient, is alert. Occasionally he's closing his eyes, but he'll always wake up when you speak to him. PCAS. So you get an ECG, you've done PCAS's online tutorial, so you know exactly what this is. You know this is a partial right bundle and he's got this T-wave inversion here. So you're thinking, okay, well, this could be, those two things could be related. And this is his chest X-ray. So imagine yourself in this situation and this is all the information that you get. And that despite the fact that you might have other questions in your mind about what you might do or what you might ask, none of them really change your, really kind of push you in one direction with the differential diagnosis. And let's just say what these same differentials are. He's a guy who's got known ischemic heart disease, who has a poor heart, he's had a surgery, maybe he's developing pulmonary edema, he's got some chest pain, maybe he's having an infarct and he's going into getting some fluid in his lungs. So maybe he needs some Lasix. GTN, but again, he's hypotensive. He's had a surgery, he's got a cough, he's got a low-grade fever, he's got something that looks a bit weird on his x-ray. Maybe he's developing a pneumonia, so maybe he needs some fluid and some antibiotics. But again, he's got apparently a poor heart. I don't really know what to do with that. Should I give him a little bit of fluid? How much fluid should I give him? Again, he's had a surgery, he's had a knee replacement, he's got a big swollen leg and he's short of breath and he's got chest pain and he's hypotensive. I mean, massive PEs on the table. So you call for help, everyone's on their way, but in the end, you're there. You've got to kind of start some stuff. So imagine you've got your ultrasound machine, which in my utopia would be in the storeroom of every ward, and you push it over there. It's nothing fancy, it's a basic machine. And you go through this same thing. You're going to look at his heart, his lungs, and his IVC. So you start off with his lungs again, because you want to make sure this guy isn't going into pulmonary edema. But instead of seeing those bright white torches which are streaming down from his pleural line before, this being his pleural line here, it's got a nice clean pleural line. It's normal. That's what lung normally looks like. If I ultrasound you guys' lungs, that's what I would see. So this guy doesn't have pulmonary edema. You check both sides, you check around his whole anterior chest as he's sitting up. This guy isn't in pulmonary edema. You then look at his heart and you're surprised. All you do is you go from the top of his tummy, bottom of his chest and have a look up at it. And what do you see? Well, just to be clear, this is the left side of his heart here. This is his left ventricle. He told you that his heart wasn't so good, but it looks pretty good. It's beating, obviously it's beating fast. I mean, you didn't need an echo to tell you that. But every time his heart beats, it completely closes. So this heart is kissing. This is a kissing ventricle. It's the heart that's dying for fluid. You also think about, if this is a PE, it's clinically a massive PE, and this guy's hypotensive and looks really unwell. And you look at his right side of his heart there, it's a very poor man's test, but again, just trying to get some ideas that might help you push you in one direction. And his right side isn't bigger than his left side. So that kind of is reassuring you just for this short little while you're trying to figure out what to do with it. Just to be clear, just in case you haven't seen echoes before, this is what a normal heart looks like. That's what a normal ejection fraction from that same angle looks like. So look at his one. It's completely closing with every beat. This is what it should be doing. That's what about 50% should be doing. And lastly, you check his IVC. What was, on that last patient, a big pipe swollen and not moving as she breathed. This patient's flat. Every time he breathes, it collapses completely shut. This guy's pipes are empty. He needs some filling. So you know that this guy, you think this guy, at least in the short term, can do with some. You can help him. You can give him fluid. You can give him antibiotics, maybe some bronchodilators. He's probably developing pneumonia. PE is still on the table, but you can sort that out later. Now, I'm realistic about this stuff. I don't think that ultrasound provides all the answers. A lot of the time you get to the end of your ultrasound exam and you've either seen nothing because you just can't see through, let's say, the lungs, and there's no even hint of where the heart actually is in this patient, or you see everything, but it doesn't help you. But I don't think that's a reason not to do it. You can do a lot of other things with ultrasound beside what we talked about. You can be a star and put in cannulas. You can be that person that, as the patient will always request, because you're the one who wields that ultrasound machine to cannulate anyone. You can look for AAAs either in the ED or when you feel a patient on the ward has got that pulsatile mass, you could wheel your machine up and tell them whether they got a AAA or not in 5 minutes. Look for hydronephrosis and kidney stones, or if you're a real star, see the patient with his sudden onset visual loss, ultrasound their eye and see their retina flapping in the back of it. But in the end, I think there's the basic skills of ultrasound are heart, lungs, and IVC. And if you could be good at that, you would be, I'm sure, taking much better care of your patients. So I have a dream. And my dream is that you guys have access to ultrasound training. That through your medical school and through your early years of training, that you should expect to be able to do this stuff. This shouldn't be a privilege for the end of ED ICU training. This should be something that's given to you, these skills given to you, so that you can care for your patients as best you can. So, and as the ultrasound machines advance, in the next 10 years, probes will be wireless. They will be small enough to fit in your pocket, and they will beam wirelessly to your smartphone and have a look at pictures. And that is the future. Once that is available, everyone will be using ultrasound day-to-day on their patients. So get out there, ultrasound some lungs, some hearts, some IVCs. Get anyone you can to look at your scans. I'm sure you'll be taking better care of your patients. Thank you.